All right, welcome everybody to the session on pancreatitis, both acute and chronic, both pediatric and adult. I'm Cheryl Garapi from Nationwide Children's Hospital.
And I'm Amanda Muir from Children's Hospital of Philadelphia. And we're going to just jump right in and kick things off. Our first talk is Year in Review Pancreas, and this will be given by Veronique Morinville.
Good morning, everybody. Firstly, I wanted to thank the organizers for inviting me to give this talk. I will speak about the pancreatology publications within the past year. I would say my most daunting task was to look at both adult and pediatric literature, and I only have 25 minutes, so I will apologize already to anybody in the room who has done fantastic research that I will not be able to cover during this short period of time. So I'm going to aim to go through a little bit about acute, chronic, imaging, disease progression, some neoplasms, some guidelines, some therapies, with a little pinch of pediatrics thrown in there. So firstly, AP. So we became very interested with respect to the amount of fluid with the waterfall publication, but another question that has continued to plague us has been what type of fluid should be given during AP. And this was a very large, prospectively enrolled study, almost 1,000 patients in various sites throughout the world, with about a quarter moderate and severe AP that looked at what type of fluid and when was it given, and whether lactated Ringer's was better than normal saline. And there were differences, obviously, in different countries and different practices. But it looks like the use of Ringer's lactate in the first 24 hours had reduced odds of moderate, severe, and severe acute pancreatitis versus using normal saline. Obviously, this needs to be replicated, but really interesting information with respect to the use of Ringer's lactate. Another interesting thing is we often look at what happens to people who have acute pancreatitis and whether there's mortality in a short period of time during the hospitalization or often within the first 30 days after hospitalization. This group in Hungary looked at, well, what happens to these people for the next year after hospitalization? And actually, compared to regular population, there's a 3 times higher mortality rate for people that were hospitalized for acute pancreatitis. So they really say we should be following people for at least 90 days after they get discharged. We should look at their cardiovascular status, local complications, and particularly people that had oncologic diagnoses were at risk of having poor outcomes. So really interesting that we should extend beyond the period of acute pancreatitis. Something else that I personally found interesting was re-looking at drugs. We've looked at drugs causing pancreatitis for years, but re-looking a little bit at what we're using more recently. So this was a look at a database that looked at IBD medications, and we know historically, and it still remains the truth, that thiopurines, 5-ASAs tend to have higher risk of causing acute pancreatitis, and it seems to be more for Crohn's rather than UC, and the same drugs used for rheumatologic diseases. What's reassuring is actually our biologic medications do not seem to have a signal, so that probably we can feel confident that they do not lead to increased risks of pancreatitis. And I'm involved in INSPIRE, but I just found it interesting that when you look at most drug publications, they deal with one attack of acute pancreatitis, and you find a drug and you might blame the drug. But if you look at people over time, you might see that they have attacks of acute pancreatitis that some of them don't have any drugs involved, and the same person might have an attack with drug and another attack without drug. And the majority of our patients in INSPIRE that are acute, recurrent, and chronic pancreatitis children, they will have other risk factors over time. So maybe we need to look at people as having drug associated in an at-risk person that might have other risk factors rather than just the drug all the time. With respect to imaging, again, because I'm in pediatrics, we're very much used to looking at age and different normals for different ages. But one interesting publication I found was looking at normals for MRCP. And it looks that traditionally many institutions for imaging have used either EUS or transabdominal ultrasound or ERCP normals for common bile duct and pancreatic duct normals. And this looked at almost 1,000 patients for common bile duct and 774 for pancreatic duct in Eastern Europe, Germany, Poland. And they actually found that we should probably hand our normal range for what we would say is normal. And in their database, they looked that actually about almost 20% of people would have been investigated for having large common bile duct or pancreatic ducts that were otherwise normal. So that maybe we need to relook at what we seem to be normal on MRCP in particular, so we don't investigate people that truly would not need to because they were controls. And very interestingly, this was a very large study that looked at over 200 referral centers in the US and Canada, looking at the placement of pancreatic duct stents in persons that wouldn't have necessarily needed it and whether it reduced the risk of post-ERCP pancreatitis. And so they looked at these people and were trying to look whether there was a non-inferiority with respect to using indomethacin and all, but whether or not they got a pancreatic ductal stent. And what was interesting for this study, whoops, I'm moving forward, is that they found actually that there was more PEP in those that just got endomethacin versus those that got the endomethacin and the prophylactic pancreatic ductal stent. And there was a 30% risk difference. Now, obviously, the individual specialists were choosing the stent selection, the number of stents, the number of attempts, and so this would need to be replicated in further studies, but this was the first best evidence of this, that we should do a combination indomethacin and pancreatic ductal stent in adults. A little bit problems with the mouse. Okay, oops, I'm going to move this way. Sorry about that. If I move on to chronic pancreatitis, one of the biggest issues is quality of life in chronic pancreatitis. PROCEED is a prospective study that is following people with chronic pancreatitis, but also has groups that have abdominal pain and controls. And what they wanted to look was what was the quality of life with these people with chronic pancreatitis. And they were using PROMIS, which are quality of life questionnaires, and looked at patients, and about 500 chronic pancreatitis patients and about half of controls over time frame. And probably very importantly, people who have chronic pain or people who have recurrent episodes of very significant pain have poor quality of life, and they will have decreased physical, mental, social health context as far as quality of life. They will have higher rates of depression, anxiety, and sleep disturbance. So we really need to look at these criteria when we're following people with chronic pancreatitis, because if we can address those, we can make a huge difference to the quality of life. Totally different population now in Europe, and we're looking at the Netherlands, and they were looking at quality of life in their chronic pancreatitis patients. Now, a lot of the European countries have more global nationwide databases, which allows for good, interesting, very broad oversights about what is going on. And they looked at them over 10 years and used a different quality of life questionnaire called Short Form 36. And what they found actually, for them, there was also an aspect of if they weren't doing well with quality of life, there was often nutritional assays issues or exocrine pancreatic function, employment status, or coping strategies, but they didn't seem to be as bad off as the American ones. So obviously different patient population, different way of looking at them. But they still felt that you needed to individualize looking at that person's problems to try to see how could you reduce their burden so that their quality of life would improve. Obviously, as I was mentioning, pain is a very subjective thing, and it really can affect quality of life. It would be really interesting if you could try to sort out abdominal pain versus pain because of chronic pancreatitis, and inflammatory profiles might be useful. So this is, again, the PROCEED trial that looked at immune profiles in different groups, whether acute pancreatitis, recurrent acute pancreatitis, chronic abdominal pain, and controls. And essentially what they saw, there were certain markers of the IL-17 pathway that seemed to be increased with pancreatitis versus chronic abdominal pain. And so if you looked at this over time, obviously this is a research setting, but in a clinical setting, you might be able to differentiate people that are having inflammatory pain from chronic pancreatitis versus whatever chronic abdominal pain is, but that you better be able to tailor what you do to them, and maybe you could tailor therapeutic interventions to block those pathways. Now, if we look at natural history of disease, I'll go back to Europe because they have nice databases, and this was a Danish registry that they looked over 18 years. And what they were interested in was looking at what happens to people over time from being healthy, getting acute pancreatitis, acute recurrent, chronic pancreatitis, or pancreatic cancer, or death. And they looked at the continuum. And if you look at this diagram, it kind of shows that they saw people essentially go from one to the other or one to the end. And it seems to be different pathways. And they had a significant proportion of people that went from healthy to chronic pancreatitis or healthy to pancreatic cancer directly from a presumably healthy state. So the question is, are different pathways that lead you to go through the AP, RAP, CP, pancreatic cancer versus healthy to pancreatic cancer? And maybe, again, it could be targets for therapeutic pathways and to block the institution to go along. And they had about 4.6 million people, so it is a very large kind of data set. I have to talk a little bit about cancers. There's been quite a few publications about IPMNs and adenocarcinomas in the past year. And one of the big things for people to deal with IPMNs is you find them, and then what do you do with them? How do you survey them? How do you keep an eye on them? Who do you do surgery on? So this was branch duct IPMNs, and they were looking at people that began without having worrisome features or high-risk stigmata and followed them over time. And if I can say is that the main thing is that they said if somebody went out to 5 years without really changing, it didn't look like their risk of pancreatic cancer developed much higher rate than the general population. And so they proposed that if after 5 years you've been relatively stable, particularly if you're over 75 years old, and then we get into cyst size, that they'll accept a higher cyst size if you're older, and 65 years old at 15 millimeters, that you might be able to discontinue surveillance because you go back more to general population risk. A different group looked at IPMNs in high-risk persons. So this is either people that have themselves germline pathogenic variants or in families of pancreatic cancers without pathogenic variants. And they looked at them in the Dutch group that had these high risk versus Italian cohort that had sporadic IPMNs. And what they found essentially was almost exclusively the ones that themselves had pancreatic pathogenic variants were at higher risk. The ones that were just in familial cohorts did not really seem to have higher risk versus sporadic. And there were certain rates that they saw that they would suggest to follow a little bit closely or to propose surgery for those growing very fast. And finally, another thing, and again, I think this is still an issue for debate and a lot more data will need to come in, but we know that new onset diabetes for certain people can herald that there will be a diagnosis of pancreatic cancer in the near future. And this looked in Denmark again, and they looked at whether the groups that had new onset diabetes that developed pancreatic ductal adenocarcinoma versus those that just, quote unquote, had new onset diabetes, if they were somewhat different. And they started to see a few different signals with respect to the age at which they were diagnosed with diabetes and their hemoglobin A1C. So again, they were saying this might be a path to follow to try to see if you can sort out the different groups over time so that you would follow them differently for their risks. Now, something very exciting, and I think many fields of cancer have to do with liquid biopsy assays. And circulating RNAs, little pieces of RNAs that are found in the bloodstream, look like they would be a potential target to find cancers sooner than we usually will typically find them. And this was to develop a panel to see if you could indeed find people and identify people that had pancreatic ductal adenocarcinoma quicker than you would normally, and testing it in combination with the CA19-9 marker. And what they did, they started off, they looked essentially at plasma from pancreatic ductal adenocarcinomas and looked at candidates circulating RNA markers and came out with 5 that they felt looked more interesting. They were able with these to identify early stage cancers versus late stage cancers. And then with the combination of these and the CA19-9, they really had a nice area under the curve for the validation cohort. And they were able to pick out people that would have normal CA19-9 because not everybody will rise that marker. So they really feel that this is a pathway to follow, that maybe we can identify people sooner using this type of technology. And it's a very promising, exciting future. Often when we are not experts in the field, we like to look at what there is out there for societal practice updates, practice guidelines, expert guidelines. So a few of these came out this year that I wanted to draw your attention to. First was the American College of Gastroenterology published guidelines on the management of acute pancreatitis, and they went through the PICO kind of pathway and did grade recommendations. And essentially, you can obviously refer to this publication, but they went through what they would recommend to people to look with respect etiology, initial management, ERCP, preventing post-ERCP pancreatitis, role of antibiotics and nutrition in someone presenting with acute pancreatitis. Another update that came out this year, we haven't talked about the Kyoto guidelines. I was talking about there's a lot of literature on IPMNs this year, and this was an update about the Kyoto guidelines that have been published a few times before in the past. Again, looking at clinical questions and what to do about them. And in this year's update, I would say the main thing is that they added extra criteria for what you can do with EUS and the cytological analysis of when you get an EUS guided fine needle aspiration. And they also touch upon this, can we stop doing surveillance and can we change our surveillance after 5 years if someone has a stable branch duct? And this will echo the other publication I was mentioning earlier on. Another publication that came out, which is more of an expert review, and this is the problem sometimes in pediatrics and in adults for pancreatology, we don't have a huge amount of data. And this was to look at exocrine pancreatic insufficiency evaluation and management. And it is mostly expert recommendations, and so they call it best practice advice. And in this document, they go through essentially what kind of etiologies could lead to EPI, so that clinicians think about it, what kind of clinical presentations people might come out with, and a pathway for both the workup and the management, including use of pancreatic enzyme replacement therapy for those that might need it over time. So nice little review article as well. Now, therapies. I think this is probably what we would hope that every year would be the biggest segment of my talk. Alas, it probably still needs to broaden a little bit more. One thing that remains problematic for people that have acute pancreatitis, we were talking earlier about fluids, is the pain and taking care of pain when people come in with acute pancreatitis. And this was a study that looked at a particular opioid to using NSAIDs and followed them essentially for the first day and a half to 2 days and then out to 3 days. And they wanted to see how much breakthrough fentanyl they needed to use. And essentially, the narcotic, the buprenorphine, was stronger or more effective than diclofenac. And obviously, you could imagine that for moderate and severe AP, there might be more pain associated, and so particularly in that group, so that we might not get away. It might be better to use narcotic for those higher risk groups than to just deal with NSAIDs that might be beneficial sufficiently for the more mild. This was still published ahead of print as of when I rechecked yesterday. This is again from the INSPIRE cohort, and this has to do with, we know we use pancreatic enzyme replacement therapy when we have exocrine insufficiency, but what about using it if we just have acute recurrent pancreatitis? And in children, this is INSPIRE, this is retrospective, so all of these caveats, but essentially looking at children that had acute recurrent pancreatitis that were not exocrine insufficient and giving them pancreatic enzymes. And it looks that when you put them on pancreatic enzymes, these children have fewer attacks of acute pancreatitis subsequently, and they're less severe. Now, obviously, this is retrospective. It's not double-blind, randomized, all these things that you would want, but it's just kind of an interesting kind of data set that will be looked into further. And interestingly, those with SPINK mutations seem to have a better decreased rate of pancreatitis. Again, is there a mechanistic role? To be determined. With chronic pancreatitis, we were mentioning pain is such a big issue, and obviously because we know that proteases are important in the activation of pancreatitis, maybe if you block these proteases, you would do better. So this was a study of a serine protease inhibitor by mouth, Camostat, and was double-blind. Beautifully done, double-blind, randomized. They had people with chronic pancreatitis that had significant baseline daily pain, different doses of the medication versus placebo for a month, and they looked at what happened with their pain. Alas, all groups did the same. There seems to be a very high placebo rate noted, and I think that's one of the issues when you're looking at pain, and maybe we need other markers to see whether there's improvement. And the authors do mention that this will be an important factor to consider in trial designs because their study ended up being negative, and it's unclear whether, well, certainly the high placebo rate may have played a role. This is not a research, but just to draw you to a very nice article that came in the New England that is a summary of cystic fibrosis, but it does touch upon, it does touch upon the CFTR modulators that obviously have completely revolutionized the care of CF. And just for you to look at. Now, there have been a few different articles that have come out over the years, but this is just in the most recent year, just to draw again that we're seeing this again and again in different populations and different modulators. You put children that are exocrine insufficient, young enough on CFTR modulators, and a proportion of them become pancreas sufficient. In this group, again, this is small groups, it's pediatrics, they did see that the age was negatively correlated, meaning that if you start them older, you have less of a chance of regaining that pancreatic exocrine function. If you start them younger, you have more of a chance. Seems very logical. We need to do this more. We need to have access to CFTR modulators younger for younger children. And now I can't do a talk without having at least one slide on AI, and whether this will be the future or an aid to us will remain to be seen. But a very interesting cohort looked at essentially looking at AI and whether you could look at images and essentially looking at scans and CT scans and to find cancer diagnoses sooner than we would have made them clinically. So they had a group that they trained and they had a group that they were validating their database, their AI model. And it does seem to work. Now, obviously, this needs to be done prospectively. We need to see, can we pair it up with some of our blood-based biomarkers I was talking about, maybe the circulating RNAs? Can we bring forward the time frame at which we will make these diagnoses of pancreatic cancer? We'll need to touch this in the future research, but very interesting stuff coming out for sure. So, this was meant to be just an overview of maybe what you haven't read over the past year. I hope that I have made it clear enough that there's been some very interesting publications in acute, in chronic, in neoplasms, and advancing what we know about pancreatitis, both in children and in adults. I think the large population data sets are really helping us kind of frame public health relevance. I do like guidelines and reviews. It does help us, especially for people that don't work in big pancreatic centers. Obviously, we have to support therapeutic trials so that we develop evidence-based practice. And I'd like to think that AI will be a tool to help us. I don't think it's going to replace us, but I think I would like to think that it's going to help us and assist us be better at everything that we do in pancreatology. Thank you so much.
We're now open for questions.
Thank you very much, Dr. Drews from Denmark. That was an excellent presentation. I really loved that. I was just wondering why you didn't mention anything about imaging, because, I mean, new techniques within MR, for example, using T1 relaxation time and so on, are able to really assess the degree of fibrosis and also maybe identify precursors for cancer and so on. So maybe that was because you didn't have time for that. Or
Yes, and I'm a pediatric pancreatologist, and as I said, I looked at so many journals, so many articles. That was one of my caveats. Absolutely, I would have needed probably a couple of hours to do justice to everything. So thank you for bringing up something extra that we probably also need to include in next year's versions, but thank you.
So
yes.
we need to go together in a more interdisciplinary way, I think, because you also mentioned AI, and I think we as doctors, we can't do much there. We need really the specialists, because there's so many techniques out there, and it's a jungle and a mass, and you really need specialists to use these techniques.
It takes, I would say, a gigantic city to take care of these patients, absolutely. Multidisciplinary care, absolutely.
Okay, thanks.
Agree with you.
Anything online?
Thank you.
Thank you, Veronique. Our next talk is by Chineye Dike from the University of Nebraska, where she's an assistant professor and member of the Child Health Research Institute.
It's 22 minutes, right?
Yes.
How do I get?
Okay. And then hit start. Yeah, should go. Yeah, it's there. And then hit that button down there.
Hi, good morning, everyone. I want to thank the organizers of this session for inviting me to present on exocrine and endocrine complications of pancreatitis. And that was a little bit of a mistake. I'm now at the University of Alabama at Birmingham, where I take care of children with pancreatitis.
That's Nebraska in here.
So I have no financial disclosures, but I would say that I plan to present maybe some controversial aspects, especially in following children with exocrine and endocrine complications post an episode of acute pancreatitis. And so this is just available evidence I'm presenting to allow us to pause and reflect on how we manage some of these children and patients, and I'm only delivering the evidence, so please accept it with some grace. The objectives of my talk would be to review endocrine and exocrine complications resulting from both acute, recurrent, and chronic pancreatitis in children, and to discuss relevant adult data and some published pediatric data on endocrine and exocrine complications following first episode of acute pancreatitis. So I'm going to present two cases. The case one is a 7-year-old presenting to the clinic post third episode of pancreatitis. And she'd been diagnosed with chronic pancreatitis after her second AP attack based on imaging findings and persistence of abdominal pain. During her last hospitalization about 8 months ago, both fat-soluble vitamins and hemoglobin A1C were normal. And then you obtain labs, and her fasting plasma glucose is 200 milligrams per deciliter. And the second case is an 18-year-old with history of biliary AP who is status post-cholecystectomy in that same AP admission. But her AP admission was also complicated by necrosis. And a few weeks later, she came in with worsening pain, and imaging showed a possible pseudocyst developing that was later drained by adult advanced endoscopy about 6 weeks later. But she presented several months later to the pancreas clinic with classic symptoms of hyperglycemia and a plasma glucose of greater than 300 milligrams per deciliter and metabolic acidosis. She was actually admitted from the clinic to the hospital endocrine service for treatment of DKA. And so why I present these two cases for us to reflect? I know that a lot of us with case one will be slam dunk, will test and screen for exocrine and endocrine complications. But I don't know about case two because she only had one episode. And that's why this presentation hopefully will highlight some of the available literature, because case two actually was my real experience, happened to me. And so some questions for us to reflect upon is which children should be tested for endocrine and exocrine complications of pancreatitis. I think with the acute recurrent and chronic pancreatitis group, many of us will say, sure, we will test, because even a North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition has a guideline and position paper on it, of which some authors on this paper are here in the audience. And so they recommend both screening and treatment of exocrine and endocrine complications in children with chronic pancreatitis. And when we talk about the acute pancreatitis group, if we look at patients with autoimmune pancreatitis, I think many of us will still say yes, screen them for endocrine and exocrine complications, because the INSPIRE group, they did the collection of case reports in literature plus those in their cohort, and also looked at those from a Belgium hospital, and saw that EPI requiring pancreatic enzyme replacement therapy was present in about 16%, and insulin-dependent diabetes in about 11% of these children. So many of us will still screen and follow them for both endocrine and exocrine complications. But we do know that EPI and DM post autoimmune pancreatitis in children can actually be transient and even resolve after treatment. And we still don't know the long-term prognosis and complications in these children, but we will still test and screen them and follow them. And then when it comes to children with first episode of acute pancreatitis, I think this is where it's very controversial. For those with severe acute pancreatitis, some people will still screen and monitor, but for those with mild episodes of acute pancreatitis, I think many people may not follow. And so I plan to present endocrine complications and exocrine complications, especially following first AP attack. So diabetes following first AP attack can actually range from 1.3 to 6% in children from what's published in literature, and up to 23% in adults. And up to a quarter of children may actually have persistent glucose metabolism abnormalities, maybe not reaching diabetes definition. We also know that it may be multifactorial in etiology, and multiple risk factors have been reported both in adult and pediatric literature. One that consistently comes across is the severity of attack, so severe AP being associated with DM. There is this nice review by Hart and colleagues in Lancet where they looked at the pathophysiology of diabetes following pancreatitis. And so we all know that from pancreatic necrosis and islet cell mass decrease and atrophy that we can have decreased insulin secretion. But we also know that in a meta-analysis by Z et al., they did see up to 11% of those without necrosis still developed DM. And so there are other factors that may be contributing to DM post-pancreatitis. One of those that is being increasingly recognized is increased insulin resistance. We know that patients with type 2 diabetes have increased insulin resistance, and many of them share the same risk factors with some of our patients with acute pancreatitis, such as obesity and hypertriglyceridemia, which may also play a role. And then genetic risk, so in the NAPS2 cohort, the North American Pancreatitis Study Group, they found that many of their patients who developed DM also had the single nucleotide polymorphisms that are present in patients with type 2 DM, and so that may also play a role. And then decreased secretion of other gut hormones, such as GLP-1 and GIP. So it could be multifactorial in etiology. And so what are the types of DM that we can see after pancreatitis? I would say some even type 1, because not only are there case reports of transient increases in the anti-glutamic acid decarboxylate autoantibodies, which is very, very strongly correlated with type 1 DM in pancreatitis, but also the NAPS2 cohort published their paper showing that in their cohort, about 35% of patients had a beta cell autoantibody, and 7% with greater than 1 autoantibody present. And this has also been seen in children in the INSPIRE cohort. So 397 children with ARP or CP, where 6% developed DM. Unfortunately, many places were not screening for this beta cell autoantibodies. But in those screened, so out of 13 screened, 5 or 38% had positive autoantibody present. The other types of DM that can be seen would be type 2, giving increased insulin resistance, as we discussed in the pathophysiology, following those co-shared risk factors such as obesity and hypertriglyceridemia. And then the one we know commonly is the type 3C or pancreatogenic diabetes from islet cell loss and associated exocrine pancreatic insufficiency. Pancreatic polypeptide, and so we know that type 1 DM patients have beta cell autoantibodies, but what may help differentiate between type 2 and type 3C is the pancreatic polypeptide, because the NAPS2 cohort also looked at their group and saw that at basal, they looked at patients who were newly diagnosed within 3 years of type 2 DM, either from chronic pancreatitis or pancreatic ductal adenocarcinoma or also other controls. And they saw that pancreatic polypeptide was significantly decreased in those with DM from CP and those with DM from PDAC. Even after 2-hour mixed meal tolerance testing, you can see that a robust response to increased pancreatic polypeptide secretion is seen more in the type 2 diabetic group versus the other two groups. And the fold chain response in pancreatic polypeptide secretion is also significantly higher in patients who just have type 2 DM, not from PDAC or from CP. And so the adults have done a lot of studies about DM following acute pancreatitis. And so this was a systematic review and meta-analysis where they included 61 studies and 34 were included in the meta-analysis. And they looked at risk factors for developing DM post one episode of AP in adults. They found several risk factors where increases the risk of developing pre-DM and DM, such as the severity of attack, the alcoholic etiology, necrosis, especially if you have greater than 50% necrosis present, of course, recurrence of attacks, and presence of other comorbid factors. Well, I know some people in the audience may be asking, but I mean, this is all adult data, are children, little adults. So I'm going to present some available pediatric literature as well. So this study was actually published in 2011. This was a retrospective study out of Texas children where they looked at 176 patients, but almost 80% of them of AP. So 16% was ARP and 4% was CP. And 26% developed hypoglycemia, and 42% of those 26% required insulin during the hospitalization. And out of those who developed DM, so like 4.5% in that entire cohort developed DM, 87.5% of those were only after one attack of AP. The severity of AP attack was associated with hypoglycemia and DM, including a family history, obesity, were also associated. It's very funny because at that time, they concluded from their paper that children may actually develop DM after one attack of AP, not what is seen in adults. So it's funny that is so far back, but it happened. And then I also want to present this nationwide population study out of Israel, where they looked at patients around age 40 and then saw the incidence of DM was 0.3%, and they looked at those who developed DM, looked at if they had a childhood history of AP or if they did not, and about 4.6% had a history of childhood AP compared to 2.5% that had no history of AP in childhood. And this significant difference remained even after controlling for age, sex, and other covariates, so very, very important. Well, I don't know if I've convinced you enough to screen all your patients with AP for DM, but even if I haven't, the ADA actually recommends screening after acute pancreatitis. This is a new guideline that came out from the American Diabetes Association this year that actually said to screen people for diabetes within 3 to 6 months following an episode of acute pancreatitis and annually thereafter. And of course, screening for diabetes is recommended annually for those with chronic pancreatitis. And so, some data on DM in children with ARP and CP from the INSPIRE cohort, the same study that found the autoantibody in 38%, 6% with DM, and 83% were on insulin. So children with pancreatitis who develop DM, most times they require insulin therapy. And then the INSPIRE cohort, also INSPIRE 2 cohort, they found 8.7% of their CP patients had DM, and then 5.9% had DM from ARP. So let's briefly look at exocrine complications. The incidence of exocrine pancreatic insufficiency after first AP attack in children can vary from 1% to nearly 67%, depending on the study you look at. We all know that EPI may occur transiently during an AP attack, and that's why many of us would still screen at least 4 weeks post-resolution of symptoms. But we also know that we all need to maintain a high index of suspicion because children with EPI may actually not have, may be clinically asymptomatic, so it's very, very important to screen them. And so this was a systematic review and meta-analysis of adult studies that looked at EPI during the index admission and then posts at follow-up. So they included 10 studies and 370 patients at index admission, and then 39 studies and 1,795 patients at follow-up, so very big. The pooled prevalence of EPI during index admission was 62%. For studies, so about 8 studies had both index and at follow-up. They saw that about 71% prevalence during index admission reduced to 33% at follow-up. So what that tells us is that even though that EPI may occur transiently during an AP attack, over half of these children may still remain exocrine pancreatic insufficient at follow-up, at least 3 months follow-up. They also saw that the risk factors for developing EPI in these patients were severity of attack and alcoholic etiology were risk factors. So what about children? EPI can also occur after first AP attack in children, and this has also been published. And so this study they saw that EPI occurred in nearly 1/3 of children after AP attack. In this study, they actually saw that, and this was a prospective study, they saw that the incidence of EPI after AP attack may increase further away from the AP episode because they saw almost a 29% prevalence at 3.5 months when compared to nearly 33% at 8 months. And that EPI persists in 62% of those that had it at first check, and that children may have EPI without clinical symptoms. And so this is a study from the INSPIRE 2 cohort, the same study we've looked at for diabetes that also showed that in their cohort, EPI was present in 33.1% of children with chronic pancreatitis and about 10% of those with acute recurrent pancreatitis. So we're going to shift gear a little bit and talk about something that could develop as a sequelae from EPI, which is osteopathy in chronic pancreatitis. So even though there are a lot of adult studies and adult literature is very robust in this area and report up to 58% osteopathy hold prevalence rate, pediatric studies are actually limited to only 2 studies, one from the INSPIRE cohort published this year and another study done in India. In the INSPIRE cohort study, the incidence was 6.4% for osteopenia, and then it was 18.6% in the study in India. And it could be because the study in India had a lot more patients, and all of them were chronic pancreatitis patients, compared to the INSPIRE cohort that had both acute recurrent pancreatitis and chronic pancreatitis in their cohort. The INSPIRE cohort also reported lower height for age Z-scores in those with CP and ARP compared to the controls. And even though the adult studies have robust literature in this area, there's actually a study that showed that despite the high prevalence in adults, it's actually infrequently evaluated in adults. So you can imagine what then happens in peds. But EPI is a risk factor for osteopathy in many adult studies. So I'm going to leave us with some take-home messages. So EPI and diabetes can occur in all children with pancreatitis, both acute pancreatitis, acute recurrent, and chronic pancreatitis. And childhood acute pancreatitis increases the incidence of diabetes mellitus in adults. The etiology of DM in pediatric pancreatitis can be multifactorial. And there are multiple risk factors that increase both DM and EPI risk in pancreatitis. Pancreatic polypeptide may be able to help us differentiate between type 2 and type 3C DM, and osteopathy may occur in children with ARP and CP and should be evaluated for. And a few topics or points to pause and reflect on. We have this highly cited paper from the Naspigen group, Naspigen Pancreas Committee, on the screening and management of exocrine and endocrine complications in children with pancreatitis. Is it time that we have one for screening and monitoring for endocrine and exocrine pancreatitis in children with first EP attack? And I leave you with a quote from my patient. She asked me one day, could you tell me why all the things I initially dreaded, I now have to do very often? And she said, I'm claustrophobic, and since diagnosis, I've had to get so many multiple scans. I hate needles, and I unfortunately had to get DM after one AP attack, and I have to stick myself all the time. And so pancreatitis takes a huge toll on our patients, and we all know about the pain and emotional toll. We report on it, miss school and work for parents. But the burden from endocrine and exocrine complications are also quite enormous. We have to always consider them regardless of the AP number or severity. Thank you. I'm happy to take questions.
This is open for questions now.
Jay Freeman from Nationwide Children's. Very well done. Complicated subject matter to cover. You did a great job. My question to you, somewhat unfair, but to the room as well. I think we all agree that the etiologies that lead to CP for kids and adults are different, and so we think of those differently. But even within like hereditary pancreatitis, that is not a uniform group. I think we could easily make a physiological argument that maybe a CFTR patient may have a different risk of diabetes than a CTRC patient, right? Knowing that we don't have infinite number of patients, we're very limited. How do we balance this idea of screening and personalized care? Do we literally just take the group and just say this is the lowest common denominator, we're going to screen everybody the same? Or how do we try to get towards personalized care so that we screen the right patients at the right time? And again, it's not an easy question, and again, I open it, I ask it more for the room to answer as well, because I think that's one of the difficulties that we have in this area.
No, that's an excellent question. I'm going to start, and of course, I'll open it up for anybody in the room who also wants to contribute. That's an excellent question, right? Who do you screen? I'm going to start with my own experience, and of course, we shouldn't generalize with personal experience. My patient who got DM has no genetic mutations, right? No family history of pancreatitis. And so I think it's balanced. It's tough to balance and say screen only those with certain genetic mutations. I think severity, we really should screen those with severe AP because we've shown consistently both in adult and children that it could be a risk factor. But just not knowing who to screen, and my patient actually presented in DKA. She had gone to an ER and they sent her home, told her she had a UTI, and she came to me with labs that showed she had DKA. And so I think it's just balancing. I don't think we have enough evidence to say screen everyone, but then you don't want to also miss those who may present that way. And so it's a very tough question, but it's an excellent question. And I'll allow Dr. Boel Hedja.
Shania, excellent talk. You really did a wonderful job. To answer Jay's point, I think we are starting to develop risk models from different risk factors, like you presented nicely. Autoimmune pancreatitis is not so benign. Even a single episode could throw the patient into EPI or risk for DM. Without even developing IBD, because they develop IBD later. But with the genetic story, it's really a mixed bag, and there is a strong signal with the CFTR, risk variants that do not cause the typical CF, that we looked at in a cohort of recurrent and chronic pancreatitis. But now, come to my talk tomorrow at 4 p.m., there is a single episode and risk models for who develops diabetes, and it's about 20% or so for pre-DM and DM combined, but the diabetes stays consistent with what you showed. It's about 4%. And if you look at it in the general population, it's like 1 in 1,000 or 10,000, I forgot, so it's 19 times more for children with a single episode of acute pancreatitis. So very similar to adult data too.
Thank you.
That was an excellent talk. Thank you. Vijay Singh from Scottsdale. So I'm not a pediatrician. I'm an adult gastroenterologist, but there are some things that we have learned along the way that I'd like to share. So it's more than genes. And it's the visceral fat environment, and therefore obesity perhaps, and not all obesity is not the same. It's the composition of the fat also that matters. Especially, it's dictated by what we have eaten. Or in adults, it's more apparent. It's over a lifetime that we have accumulated things that we would not have accumulated if we had not consumed, such as essential fatty acids. We think it's great, but when it becomes excessive, that demarcation goes away. So that is what we see is a big determinant of outcomes. It's not the initiation. The cause may be the same, CF, genetics, PRSS1, biliary, alcoholic, whatever. But the modifier of outcomes ends up being the visceral fat amount and environment and composition. And perhaps that's something to be looked at maybe in the pediatric population too, since the amount of obesity is going up and the composition is changing. Just a thought.
Thank you so much. Thank you for that contribution.
I had a question about the use of GLP-1 agonists in people who have had even a single episode of acute pancreatitis. Do you have a stand on that?
No, I don't. I don't know I don't know if there is really evidence to support that. No. I know there is none in children, but.
Yeah, so all the studies have been done. The patients who had a history of pancreatitis were eliminated from the studies, but there wasn't an increased risk of pancreatitis in the people who were treated. But it isn't our population, so it's a little bit out there. But
Yeah, thank you.
Anyone else? Nope. Well, thank you very much.
Thank you.
Now I'd like to welcome Sarah Organ from Cincinnati Children's Hospital, who will be presenting nutritional parameters following first episode of acute pancreatitis.
Here.
Thank you for that great talk. It kind of segues perfectly into mine. And thank you for having me here today to share our research aimed at understanding nutritional parameters following the first episode of pediatric acute pancreatitis. And this work would not have been possible without the help of my colleagues and my mentors. Let's see here. How do I advance? There we go. Okay. So the objectives of my talk today are as follows: to highlight the scope of the problem and our current knowledge on the impact of acute pancreatitis on nutritional parameters, to review the objectives and methods of this study, to examine some of our results, and finally, to discuss some possible screening recommendations stemming from our findings. So what is currently known about acute pancreatitis as it pertains to nutritional parameters? We know that the incidence of pediatric acute pancreatitis continues to rise, with 1 in 4 children having moderately severe or severe AP. In children, chronic pancreatitis is associated with undernutrition, and in adults with chronic pancreatitis, there's been found to have lower muscle mass and higher rates of vitamin A and E deficiency as compared to healthy controls. According to ESPEN guidelines, all adults with severe acute pancreatitis are considered to be at risk for nutritional deficiencies, and in adults with chronic pancreatitis, annual micronutrient screening is recommended. So what is currently, let's see. So while I've highlighted what we know about risk for nutritional deficiencies in adults and with chronic pancreatitis, the nutritional impact of a single episode of acute pancreatitis in the pediatric population is not currently known. Therefore, the objectives of our study were to determine the prevalence of nutritional deficiencies following an index episode of acute pancreatitis and to identify risk factors for poor nutritional outcomes. Some of our hypotheses were that the index AP will confer increased risk for nutritional deficiencies and that severe acute pancreatitis will be associated with a higher prevalence of nutritional deficiencies than those who had mild acute pancreatitis. Our methods are outlined here. This was an observational cohort study including patients 21 years of age and younger with confirmed acute pancreatitis. The patients were recruited and enrolled prospectively at the time of their presentation, beginning in February of 2013, and then followed forward over time through August 2022. We began a clinical initiative in July of 2018 to standardize patient care and to bring post-AP patients back to clinic at set intervals at 3 and 12 months after their initial attack for evaluation. And to note, 90 patients were enrolled before the rollout and 91 patients were enrolled afterwards. And clinically, these cohorts did not differ from one another. Across all patients, laboratory evaluation was at the discretion of the primary gastroenterology provider. So here's just a schematic of our study flow. The patients were identified at admission and enrolled at that time. Clinical variables were collected, and then again at 3-month and 12-month follow-up, along with anthropometric data. Here we detail the variables that we collected from each patient, and this included anthropometrics such as height and height z-score, weight and weight z-score, and BMI z-score across all encounters. We documented the AP severity as defined per the NASPGHAN guidelines, and here we show the labs that were collected at 3 and 12 months, and abnormal lab values were defined per the published pediatric reference ranges, and I'll show those in the coming slides. We defined prediabetes and diabetes status per the cutoffs published by the American Diabetes Association, as you can see here. And then we defined EPI with a fecal elastase less than 100 micrograms per gram of stool. You can see here our statistical analysis. The data were analyzed using SAS. We looked at continuous data and summarized as medians with interquartile ranges or means with standard deviation. And then we used t-tests or the Wilcoxon-Mann-Whitney tests for comparisons. And for categorical data, we summarized with counts and percentages and used chi-square tests and Fisher exacts to compare the two. And we set our statistical significance at a p-value less than 0.05. Here you can see the baseline characteristics of all 181 patients at the time of their index AP. As you can see, the median age was 13.7 years. Patients were about half male. The BMI z-score was in the normal range, and the majority of patients were classified as mild AP. About 1/3 of our patients went on to have another attack during the study period. This slide depicts the findings for patients at the time point of 3-month and 12-month. So from the 181 patients, you can see that 138 and 139 had follow-up labs. And as you can see at both time points, the majority of the patients, again, had a normal BMI Z-score, which had minimal change since their index AP attack. The majority of patients had a normal hemoglobin A1C and were not diabetic. And only 22 and 25 patients, respectively, submitted stool samples. None of them met the criteria for EPI. 24 and 18% of patients, respectively, had a low albumin, which we defined as less than 3.5 grams per deciliter. Looking at more of the laboratory values obtained at 3 and 12 months, we can see here that 8% of the patients had a low vitamin A at 12 months, 5 and 6% of patients had a low vitamin E at both time points. About 15% of patients were deficient in vitamin D at both time points. 4 and 9% of patients had a prolonged INR, and 32 and 23% of patients had a low hemoglobin defined as less than 12. We then compared these nutritional parameters at 3 months in those who had had a severe attack versus those who had mild. And the significant findings included a decrease in BMI Z-score from baseline in those who experienced severe acute pancreatitis as compared to those who had mild AP. An increased incidence of low vitamin E was also found in those who had severe acute pancreatitis and compared to those who had a mild course, as well as a lower hematocrit in those with SAP as compared to mild. And there were no other statistically significant differences noted at 3 months between those who had mild and severe. We then compared the same nutritional parameters in those who had severe and mild disease at 12 months, and we found that there was a significantly higher incidence of pre-DM and DM in those who had experienced severe acute pancreatitis, but there were no other significant differences noted, and this is just showing that. This figure depicts the incidence of nutritional deficiencies at 3 and 12 months post-AP stratified by the diabetes status. On the x-axis is the deficiency of interest, and the y-axis is the percentage of patients which meet the criteria. And the gray bar represents all of our patients, where blue bars are no diabetes and orange is pre-DM or DM. And there were no significant differences in the prevalence of nutritional deficiencies when stratified by diabetes status. As we discussed in the preceding tables, there was a statistically significant difference in the BMI Z-score at 3 months in those who had severe acute pancreatitis and approaching significance at 12 months. This table highlights the percentage of patients with nutritional labs that were obtained before and after our clinical rollout, which was aimed to improve our nutritional screening. And as you can see in general, this rollout was very successful in ensuring that more patients obtained labs. So to summarize the key findings from our study, we found that pediatric patients are at risk for endocrine derangements, anemia, and all fat-soluble vitamin deficiencies after even 1 episode of acute pancreatitis. We found that 1 episode of pancreatitis had an equal prevalence of nutritional deficiencies as compared to those who went on to have recurrent episodes during our study period. We found that severe acute pancreatitis confers an increased risk for a drop in a BMI Z-score at 3 months post-attack, and this persisted at 12 months. We found that severe acute pancreatitis increased the risk to develop pre-DM or DM. And finally, our initiative to promote lab evaluation significantly improved the rate of these labs being obtained. Given these findings, our group had the following recommendations. All patients should receive routine screening and treatment for nutritional deficiencies at standardized time points following an index episode of acute pancreatitis in conjunction with endocrine and exocrine pancreatic testing. The implementation of an order set may help to improve screening metrics, and ongoing studies are needed to determine the risk factors for severe and persistent nutritional deficiencies, as well as to determine what the optimal repletion and monitoring strategies might be. Thank you again to all my colleagues, for which this important work would not have been possible, and for DDW for allowing me to present. This was a picture that we had with our Pancreas Care Center recently at the NPF Gala celebrating Dr. Vitale. So thank you.
This abstract is now open for questions.
So we didn't have vitamin D, vitamin A, vitamin E before their attack.
Correct.
So do you have any information about, I don't know, just the general prevalence of vitamin D deficiency, vitamin E deficiency,
That's a
vitamin
great
A
question.
deficiency in your population?
we know that many patients are vitamin D insufficient and deficient at baseline. So, you know, to what degree these patients differ from that, I think is in question. But we don't have baseline kind of labs in our population for A and E. And obviously we couldn't get the labs at time of presentation since most of them were very inflamed. And so the labs would not have been useful, but that's definitely a limitation.
You know, I was quite intrigued with the number of nutritional deficiencies at 3 months. I was just curious, and I might have missed this, was it more in those with severe versus acute, mild, or can we compare to non-pancreatitis patients or some other condition, just to frame this finding? It's very intriguing.
Yeah, I think, you can see that the severe had more patients were deficient, but there were deficiencies in both. But yeah, it seems that severe confers an increased risk of more deficiencies.
And you're right. And I was wondering why the non-severe got deficiencies at 3 months. I'm just so intrigued by that.
Yeah, we also have a couple of thoughts. One would be potentially that patients are kind of decreasing their fat kind of intake related to pain around that, like kind of in the immediate post-AP episode. We also know that acute pancreatitis alters the microbiome, and so potentially there's changes in malabsorption and maldigestion. And then while none of our patients met criteria with stool testing for EPI, you know, less than a quarter of our patients submitted stool testing, and also we know that that's transient and there are limitations, so potentially there was more EPI than we even really appreciated. So kind of more to come going forward.
Sure, and you have a great maintained MySum, but just as I was standing here, I was thinking maybe compared to acute cholestasis, something that causes an acute episode, and see what happens 3 months later.
That's a great idea.
Yeah.
That's a great idea. Thank you so much.
Excellent talk. I was curious, and you may have done this and just not presented it, but were the patients who had the deficiencies, was it the same patient who would have multiple ones?
No, so what it could be, it was just a snapshot at 3 and 12 months, not necessarily that same patient persisted over time, if that makes sense.
Well, I just mean because if your albumin is low, for instance, you know, you would expect vitamin A is probably going to be low.
Right.
If you have diabetes and hypertriglyceridemia, your E is going to be falsely elevated. Is it the same, is there this group of patients who have multiple derangements that is really someone that we should be following?
Yeah, that's a good question. I think we looked at it as singular deficiencies and not as a whole picture. We did do control for albumin, and none of that kind of was significant in these findings. Yeah, it's a great point, though. Thank you. Thank you.
Thank you.
Okay, I want to apologize again to Dr. DK for getting her institution wrong, and apologize to the University of Alabama. The next guest, I know exactly where he's from. The next speaker is Jay Freeman. He is a professor at Ohio State University and the medical director of the Pancreas program at the Pancreas and Liver Care Center at Nationwide Children's Hospital. 22.
All right, we got everything up there? Wonderful. All right, well, thank you for having me. I was given the task of genetic testing and imaging in chronic pancreatitis, a very narrow topic that can easily be fit into a 20-minute talk. So we're going to go ahead and jump into it here. These are my disclosures over the last 12 months, none of which will be pertinent to today's talk. So when I started thinking about the objectives for going over this in a mixed pediatric adult group, oh boy, was really my first thought. What am I going to do? Well, I'll tell you what I'm not going to do. I'm not going to read guidelines and position papers, and I'm not going to tell you what test to order. I'm going to assume in this room you guys know when to order genetic testing and when to get an MRI versus a CT, so I did not think that would really be worth our time. What I do want to do is maybe provide some updates on how we're using our current imaging and tools, and really more than anything, I kind of want this to be a little bit provocative, I guess. I'm really just taking some select articles that have come out in the last 12 to 18 months and see if that gives us a glimpse into the future. Where are we headed with our new technology, of which there is quite a bit out there? So jumping right into our genetics and chronic pancreatitis. So we know the big genes. Again, not going to run over those with you guys. But this was a really great study done in France amongst adults with idiopathic chronic pancreatitis. And between the years of 2002 and 2016, they performed genetic testing, which included PRSS1, SPINK1, and CFTR. Now, one person in the audience dared me to phonetically pronounce all of these mutations, and I will not do that or throw that person under the bus, but it would be funny if we did so. In 2021, though, they did repeat testing with next-generation sequencing, where they expanded and also expanded the coverage of our common genes, such as SPINK1 and PRSS1. And the reason I bring this up is I get asked multiple times by families, what is the point of the genetic testing? What are you going to do different for my patient when you know this information? And a lot of times it has a point of just giving them an answer as to why their child, or in this case adult, has idiopathic chronic pancreatitis. But the other thing we always talk about is if we don't find anything now, we can always go back and look at that genetics later, right? And that's essentially what this group did, is they went and they looked. And what they found was 25 new mutations in 24 different patients. So on the, let's see if my little bullseye thing's working over here. No, not now. But on the left hand of the screen, you have the 24 patients with their initial genetics, which many of them, over half, had a mutation in the CFTR gene. But on reanalysis, you see that there is a majority of these patients that have new mutations, primarily in CTRC, which was not picked up in the first one, as well as TRPV6, which again was not in that initial analysis. There's also a handful of patients who did have PRSS1 mutations. And in general, there were 7% of the population that on retesting were found to have a genetic possible risk factor for the development of chronic pancreatitis, of which 6 or 20 of these patients, this was a new cause. And so I think this highlights the idea that especially amongst the adults who have idiopathic chronic pancreatitis, or even in our kids as we learn more about the genetics of chronic pancreatitis, there is a rationale to go back and recheck previous results. And that's one of the nice things about some of the platforms that we have now that especially are being done on an exome or genome backbone, is we do have this utility to go back 4, 5, 10 years later and reanalyze these samples to determine if they truly have a hereditary risk factor. Going back to my point that I said earlier is what does it matter? You know, if I get a patient, I tell them, great, you have a PRSS1 mutation, they say, well, how are you going to change my management? Right now, we don't really have that drug. We don't have that change in management. But maybe there are factors that we're overlooking. So I thought this was a very interesting study that looked at 160 women who were pregnant and had idiopathic chronic pancreatitis and who had undergone a genetic evaluation. Within this group, 65 are known to have a gene mutation, with 95 with a gene mutation, 65 without. And although there's some really cool tables and some good figures, this is one of the times where the visual abstract really does a great job of getting the point home. If you look at adverse pregnancy outcomes, which in this study is defined as spontaneous abortion before 28 weeks or premature delivery before 34 weeks, you can see that those women who had a genetic risk factor for pancreatitis had an odds ratio of about 2.5 for having an outcome. And this was most pronounced in the SPINK1 mutations. And really the SPINK1 completely drove this analysis, with the other genetic mutations really having little effect. Now, this was a Chinese population in which SPINK1 is overwhelmingly the most common mutation, and so it has to be taken with a little grain of salt when we think about other populations. But it definitely starts to get at this idea that I think we're going to see that these genetic risk factors associated with chronic pancreatitis may have impacts with other aspects of life. We already talked about fat accumulation and how that means, the severity. There's work being done on fat accumulation of the pancreas right now, our metabolic changes for how we define liver disease. All of these may end up contributing and being implemented together. Switching over to microRNA, which admittedly is a little bit of a gray area for genetics talk. It's more of a biomarker, I understand, but I think I'm going to tie it into the genetics just a little bit. So this was a study of 40 patients in the Dallas area who were undergoing TPIT with some healthy controls. And what they really wanted to look at was whether they could use these microRNA samples to either stratify or segregate these patients with different types of chronic pancreatitis, and then if there was any predictive factor after TPIT. So as you can see with the color dots, the healthy controls are that light blue, and they group together really nicely. They're kind of in the middle right. Again, I wish I had a pointer, but I don't, so it is what it is. But for all the other causes of chronic pancreatitis, it's like somebody just threw a dart who wasn't very good like myself, and it just landed wherever. So unfortunately, the principal component analysis did not really group these patients at all in any meaningful way. And if with all these different AUC curves there to your right, don't worry about which microRNA they are. I think the take-home point is as they looked at all of these different RNA, just simply to look at whether they distinguish between chronic pancreatitis and those without, there really wasn't anything very discernible that came of it. There were a couple of the microRNA that had AUCs in the 85% range, but really nothing that we would take home as being anything better than what we have now. So why am I showing this? Well, I think we end up getting into this next layer of analysis, right? So even though we don't see a clear signal, with updated genetic approaches, we can start looking at interactions between these microRNA and what their biological function is, and even how they interact with each other. So on your left is looking at these microRNA and what the metabolic pathways that they would be involved in. Not surprising, morphine is on there because these are chronic pancreatitis patients who are going to TPIAT. So the fact that microRNA was established with the morphine pathway is not surprising. But maybe the glucose pathway that seems to be highlighted there, that might be a little bit more interesting. And then we start looking at how these mRNA are going to interact with each other. And do not ask me to explain that. It just looks pretty, right? I can see that there's a lot of interactions going on. But again, when we get into the machine learning and we start actually analyzing this at a really high level, we can start analyzing these pathways and start coming up with genetic pathways or genes of interest. And that's exactly what this group did, is they identified roughly 112 genes from 120 or 187 variants that would be genes of interest that might be looked at for chronic pancreatitis. I think some of this is very reassuring because some of the big names are on there. PRSS1 is on there, SPINK1 is on there, and now we have new genes that we can potentially look at that we can take to the lab, to a mouse model, to a cell model, and determine if they have any impact either directly or as a modifier of chronic pancreatitis. Now back to what their initial goal was, does any of this predict outcomes post-TPIT? So this is looking at some of the microRNA and their association with hemoglobin A1C and glucose. And they make these pictures look really good with that, kind of dark gray and showing a statistically significant association between the microRNA and these outcomes. But as you can see, those dots are still all over the place. And the coefficient, the correlation coefficient is actually pretty weak in most of these at around 0.2. So I would actually argue, even though there's a statistical significance, there probably isn't a whole lot of utility in testing this at a regular level. And if we look at the 3 and 6 month and even the 12-month outcomes, it's really a very similar story. We have statistical significance. We have a mean line that looks pretty impressive, but when you really look at the correlation coefficient and where those dots are, it's a little all over the place. So I don't think microRNA, at least right now as we see it, is something that we're going to be ordering. It's something that we're going to be looking at in a clinical setting. But from a research perspective, how these microRNA may interact in the genetic pathways that may come from them, they may have utility as we look to further understand chronic pancreatitis moving forward, and especially what the genetic modifiers are, whether it be brown fat, white fat, all that type of stuff, or if it's something else that we don't know about yet. And of course, we are seeing new genes being discovered. One of the other real benefits of platforms that use whole exome or whole genome is if you do send a genetic test and you don't find anything, you can often reflex, and every now and then you'll find something new. And that's the case with the CUZD1 gene. This was in a Polish pair of sisters that this was initially found in, and then shown in a European chronic pancreatitis cohort. The mechanism for this is really not well understood yet. We're thinking it has something to do with trypsin modification and regulation, but still more to come from that. And then one of the newer ones is the CLA3B, so a chemotrypsin-like protein enzyme or protease. That was, again, mostly from our Hungarian and Polish colleagues, and they were able to show this in a European cohort. Then there was a Japanese cohort in pediatrics that looked at 90 children with chronic pancreatitis, and they actually found variants of this as well. So I'm not going to belabor the point, but I think it just hammers home that we are going to find new mutations. We're going to find new modifiers, and keeping these genetic samples is going to be important. I think one of the areas that we're having the most interest at right now are these P and LIP variants. Did Mark leave? Hey, that works out well for me. I don't have to actually go over his work and have him tell me what I did wrong. All right. So these PNLIP variants were first really recognized in about 2019, again in a European cohort of around 370 patients. Where they were able to identify this. And then they looked further in another European population that had either familial or hereditary pancreatitis history. Now, I found that a little bit unusual categorization. For this paper, familial meant that they had one family member who had symptoms or signs of chronic pancreatitis. Hereditary meant they had two or more. And what they found was that in addition to 2 known variants of this gene, they actually found 6 more that seemed to be associated with chronic pancreatitis in this cohort. And so the thought at this point was based on in silico testing that this was a misfolded protein that was actually getting stuck in the endoplasmic reticulum, causing stress within the acinar cells. So very similar to what we see with cystic fibrosis and delta F508 or some other conditions where we know there's all that ER stress. So this led the group at Washington University in St. Louis to propose and create a preclinical mouse model using this variant here. And I got to say, I found it quite interesting. So we have wild-type mice, heterogeneous and homogeneous. And if you look at the pancreatic weight of these mice, you can see in a stepwise fashion that those with the wild type had the largest pancreases, and it sequentially came down to those with the homozygous mutation having very small pancreases. This was basically the in-lab version of atrophy. And if we look at the histology, again, the wild types on the top, homogeneous in the middle, and heterogeneous, you can see the histology essentially unchanged out to 12 months for our wild types. But look at how much damage there is on the right side of the screen, and how much acinar cell and just disarray there is with this. And even in the heterogeneous with one mutation, you still see that that structure is very different, showing that there really is a signal that this is causing damage within the pancreas. When we look at staining for fibrosis, again, we have wild type on the left, and you see all that blue on the right in the homogeneous. So you start actually seeing pancreatic fibrosis with this mutation. And then when they did electron microscopy, top left in the gray, there's your wild type, really nice organized endoplasmic reticulum, whereas with all the others, you see this endoplasmic reticulum blown up, looks like huge streets with lots of collagen displaced in there. So again, lends to this idea this was a folding defect causing cellular stress, primarily in the endoplasmic reticulum. And when they looked at trypsin, lipase, and amylase, so the ones with the triangles in the darker gray are the mutated, the white are the wild type. And early on, you actually see that the trypsin is higher in those with the mutation and then falls at around 6 months of age, whereas lipase and amylase are impaired in those mice with the mutation. So I think this is a pretty compelling story, at least in a mouse model, that this mutation is really doing damage to the pancreas. This was then taken in a paper that's not even fully out yet, that's just out on PubMed, in a Chinese cohort where they again looked at these variants, and they found 12 variants in their population, and actually took the 8 that had these novel missense variants and used a HEC 293T cell platform, and actually looked at how they functioned to see if it made sense that these were causing chronic pancreatitis. And what's interesting is it seems like there's only certain variants. So when you looked across everything, it wasn't all of the P and LIP variants, but there were certain ones. In this population, the A433T, which is kind of there on the right side, seemed to be functioning very differently. It actually had a lot more relative abundance within the cell, and even in the soluble samples. So again, that's this idea that it's building up within the cellular structure as well. And there's also some with these other variants. Interestingly, the first variant is actually this F300L, which is kind of there in the middle. And at least in this population, it didn't seem to have as much physiologic function. So right now, there's a little bit of debate as to whether these variants that are causing folding defects are more likely the ones that are having more of a clinical impact, or if there's some other mechanism that seems to be causing, or at least predisposing these patients to chronic pancreatitis. So I think there's going to be a lot more to come with this gene, and that's why I wanted to highlight it here today. The other thing I'd like to say is not all genes are bad. So we at least have one study here, also from the French group, where they looked at PRSS3P2 and TRY7 and actually showed that having a combination of these two mutations was protective against the idea of having chronic pancreatitis. This was pretty uniformly seen in French, German, and Japanese cohorts, maybe not quite as pronounced in the Indian cohort as you see there on the bottom left, but when you do the full meta-analysis of it, it seems to be a protective combination. So I think we will have to remember that some of these genes are our friends as well, and they may help protect us, not just harm us. And the last thing from a genetic standpoint that I want to just touch on is, we think of this as being multiple pathways. I kind of asked the question earlier. We have figures like this that we kind of conceptually think of, but we really know there's multiple pathways, and this is just 3 that are shown. And so as we start thinking about these mutations, how they cause chronic pancreatitis, what their long-term risk factors are going to be, I think we are going to have to kind of categorize them, at least in our head, a little bit more based on what their physiology is. So with that, I'm going to turn it over to imaging. Again, I am not a radiologist. I may have stepped way out of my comfort zone. I'm not going to talk about T1 diffusion or fibrosis, unfortunately, but hopefully we'll talk about something that's interesting. So as was noted, we are starting to see more standardized protocols come where we try to limit either radiation or length of time, especially for our young kids who may not be able to tolerate an MRI scanner for very long. So the consensus MRI protocol for children was led by Andrew Trout as part of one of the INSPIRE initiatives. People in the room are involved in that. Kind of gives us an idea of what the bare minimum is for imaging a child with pancreatitis. And we also know that chronic pancreatitis is very much a definition that comes from a lot of our imaging. And so the CPD-PC group has started this mini-map study where they're actually looking at the different criteria on imaging to redefine how we think of chronic pancreatitis. Because especially in the adult population, there's this idea of catching early versus late chronic pancreatitis and intervening before that. Again, I'm not going to read those to you. I just want you to know they're there. But I think we do have ways of actually scientifically looking at these protocols. So this is one actually from a Chinese group looking at 40 patients with autoimmune pancreatitis, where they really prioritized intra and intra-observer variation. So they took these follow-up scans, and they had Dr. A, who has over 20 years of experience, Dr. B, who had 7 years of experience, and they compared a full protocol versus a shortened protocol for AIP over time, and looked at was there intra and intra-observer variation, and did you get the same benefits from a shortened protocol? And there's a lot of numbers and a lot of data on here. I think if you just look at sort of these consistent analyses, they're all close to 1. And at the end of the day, when we looked at everything between Dr. A, the first time he read it, the second time, and how Dr. B did, and how it correlated to their disease progression, it was almost 85% and above agreement. And so I do think that this shows that, one, there is a way to shorten our protocols in a meaningful way, and there is a way to study this so that we can feel good about that, as opposed to just having consensus recommendations, which is what we largely have to practice off of. Now, I'm remiss to talk about imaging without talking about radiomics a little bit. And so this was a very interesting study to me, looking at this radiomics clinical combined model to see if it helped distinguish between pancreatic cancer and mass-forming pancreatitis. So as the flow diagram shows, they basically ended up with 2 cohorts. A developmental cohort of around 175, 200 patients that did not have FNA, and then they used the FNA group as their kind of validation cohort. And so they took a very normal approach. You recognized a region of interest. They did data extraction. They used 2 models. A lasso is a combination of radiology imaging characteristics with clinical characteristics. Same thing for a principal component analysis. And then they developed models. And so they were able to identify here on the upper left, we can see variables of interest. And then I think we can just go ahead and look at really what the performance was. And you can see that sensitization for clinical only and specificity was lower, as there was the area under the curve. Not surprising, as you added more variables, you started getting a better sensitivity, specificity, and area under the curve. I think what's interesting here is if you look at the principal component analysis that combined both radiomics as well as clinical characteristics, it actually performed better than those samples that had FNA. So this was some, and this is shown in the areas under the curve with all the pretty pictures on the side as well, but this really gives you the idea that we can start thinking about not having to do more invasive sampling of some patients if we have better radiomics. But we also know that radiomics is is of interest. We can see how the searches are going up. It has a very defined protocol for most areas, but it's really not the whole story, and it's not where we're going, is it? We know it's this guy, right? It's the elephant in the room is artificial intelligence, right? And we know that artificial intelligence is growing and it's coming. And I want you to keep this picture in mind a little bit as we move on. So I picked up my favorite bioengineering journal that I'm sure is at your bedside as well, and did my best to look at how they're using this pixelation and teaching AI to inform our radiology. And so in this study, they had 25 patients with adenocarcinoma, 13 PNET, 6 pancreatitis, and 4 spins. And they had this process, again, of extracting from an area of interest in that very hazy picture there. And they were able to then look at images that look like that. And I don't know about you, that means nothing to me. The simple guy who grew up in Kentucky sees lots of pretty pictures and lots of colors. And they did all of this high-end analysis where they looked at diffusion constants and all this other stuff. And at the end of the day, they were able to show that looking at the radiomics as an ADC with this enhanced imaging gave you an accuracy of about 90.7% versus old of about 90.5. Precision's about the same, specificity the same, scores about the same. So even though this looks really cool and it knows it's where we're going, I think right now, and as shown in this next study, that really AI is a teenager. And what I mean by that is if you ask AI a question, it will give you an answer, and it will tell you it's correct. But it needs some growth. And why right now it's really exciting, and I think we're going to get there, and it's going to transform the way that we practice. I think right now the reality is the tools that we have are working as well as AI, but that will come. So my summary is I am neither a geneticist, radiologist, or even an engineer, but hopefully some of the stuff that I showed today was interesting. I think these areas are rapidly evolving, and they are going to change the way we practice today and in the future. We don't have to be a radiologist or a geneticist for this to be of interest, and we need to have some understanding of how it's being used because it is going to impact our patients. And I think as we move forward, AI will leapfrog what we have now, differentiate tumors from pancreatitis, chronic pancreatitis, and then that earlier detection of chronic pancreatitis, which is in some ways the holy grail that we're really looking for. So with that, as long as they're not too tough, I'll be happy to take some questions. Thank you.
We are now open for questions.
I feel like I thoroughly confused the room. All right. I have a comment. Yeah. Go ahead, Linda.
Hi, Linda Cummings. I'm at University Hospitals in Cleveland. I'm an adult gastroenterologist, and I have a question regarding genetic testing for causes of pancreatitis in a patient with cystic fibrosis who's had several attacks. Can you talk briefly about the different options for the testing, and like how does one decide which panel to send out for? And also the sample, like is it better to send blood versus saliva? Sorry if this is a basic question for everyone else, but I don't see as much of it.
Yeah. No, thank you, Linda. Happy to talk about it. So I think the reality is a lot of us are a little bit hand-tied by whatever our institution will allow us to do in some ways and what contract we have. I prefer serum testing we use prevention genetics is what we use, so it's got about 11 genes on the panel, but again, it's ran on a whole genome backbone. And to me, I think that is probably one of the most important traits when I'm looking at a genetic test. And it goes back to this idea that I want to be able to look at whatever comes next that I don't know about in the future to potentially help my patients, because I do think that's going to be important. Now, the cost is sometimes limiting for some patients, so the aerial saliva test is perfectly fine. If I can't get, my preferred test, I think that's a great test, and I have no problem getting it. Usually we can get that relatively cheap and not have any problems. Now, having one mutation, as was brought up at least in a conversation on the side, does not mean that you can't have more than one mutation. And we saw that in the French study with all those patients that had a CFTR variant, and then many of them had a second variant. And the way I try to describe this to patients is it's not 1 + 1 = 2, it's 1 + 1 = 10. There is a synergistic effect of having multiple mutations. that with anatomical variations as well, I think makes a huge difference. And so in a CF patient, it's worth still sending genetic testing to make sure they don't have a PRSS1, a SPINK1, because I can tell you many of us in the room have patients that are exactly that. Sorry, my son, go ahead.
Jay, excellent talk. Congratulations. I wanted just to comment on kind of a reflection of the role of dealing or working with scientists when you're handling big data. It is truly the time and the era for that. So in terms of genomics and radiomics and even transcriptomics or proteomics, the scientists are really excited to work with pancreatology scientists or clinician scientists, but it comes on us at this time to really sort our data in a very systemized fashion and ascertain the cohort and tell them the endpoint. So it's really on us to develop the hypothesis. And it's a lot of fun, but it's honestly that the field is ripe now for all of us to tap into it. So very nice summary for it. But I wanted to tell people, maybe don't be afraid. If you have a good source of data, partner with your scientists who would need your guidance, though, a lot of the step of the way to do that. Because for pancreas, most of them would tell you we never touched a pancreas-related question prior.
No, I 100% agree with you. And I guess the only thing I would add to that is working with that statistician at the very beginning is so important. Because as we all know in research, how we acquire the data is sometimes as important as the data we acquire. And having it in a usable format that the statistician can then transition to SAS or R or whatever format they're going to use, that's critical. I mean, you can lose a year of your research time just organizing data if you're not careful, especially with big data.
Anybody else?
Cool. All right.
All right, well, we're on time, so thank you very much.
Thanks.